Allow me to introduce to you our first speaker, Dr. Ashley Kalinauskas. Dr. Ashley Kalinauskas is the Chief Executive Officer at Torigen, and she obtained her degree in veterinary pathology and pathobiology at the University of Connecticut. She also obtained her master's degree in engineering, science, and technology entrepreneurship at the University of Notre Dame. And she's also on the Idea Center Advisory Council at the University of Notre Dame. And Dr. Kalinauskas will have a presentation on the role of immuno-oncology in veterinary medicine. Let's all welcome and give Dr. Ashley Kalinauskas a warm round of applause.
Oh, perfect. Thank you so much. I truly appreciate it. Let me pull up my presentation right here and go into presentation mode. All right, can you see everything okay?
Yeah.
Perfect.
Yeah.
Well, really excited to be here today in order to tell you more about really the role of immuno-oncology in veterinary medicine and the active role that Torigen is taking in order to really be able to advance companion animal oncology moving forward. So we're excited by the leaps and bounds that are being made in this field, and we're really focused on being able to pave that way. So when it comes to cancer diagnoses in companion animals, sadly, over 4 million dogs and 4 million cats are diagnosed with cancer each year in the United States. This is significantly more globally. But when it comes to actually being able to treat those pets, less than 1 in 10 owners actually go to see a veterinary oncologist. And once they go to see a veterinary oncologist, now options for chemotherapy and radiation therapy can exist. But we believe that more options need to be made readily available for those owners. And really why they don't go see an oncologist is there's a complete barrier between being able to get a diagnosis and then go get the help that they need. So 50% of all dogs over the age of 10 die from cancer, and 90% of these dogs will never see a specialist. So after a cancer diagnosis, what happens is that pet is really seen in their primary care doctor, and that primary care doctor can offer a referral. They can perform surgery, or what most likely happens is they move forward with hospice care and comfort measures. When it comes to actually being able to get in to see a specialist, there's not only a geographic distance, but there's long wait times. Out-of-pocket costs can exceed $20,000 US. There's a concern for adverse events and side effects, and also a time commitment. And when it comes to specialists, now the specialists, when you actually get in there, they have options for chemo, radiation, advanced surgery, other investigational therapies, and access to clinical studies. So we really feel that pet parents need effective cancer treatment options that are more affordable and accessible than chemotherapy and radiation. And veterinarians actually need tools in their toolbox in order to help these pets. So at Torigen, it's our goal to really be able to build that future and to build that toolbox. And how we're doing that is really being able to be focused on a multi-product approach and a pipeline. So our first product is an autologous cancer vaccine that utilizes a portion of the patient's surgically resected tumor in order to create a personalized therapy to give back to the patient to help stimulate their immune system against the cancer. We did over $1 million in revenue last year. We're rapidly growing, and we're really rapidly able to utilize the information that we're gathering in order to build out our next line of therapeutics. So we've assembled one of the largest canine tumor banks that is able to be used both commercially, but then from a research perspective, in order to understand activated targets that we want to potentially move forward against, or different tumor types and genomic markers that we would be able to have access to really understanding what is creating a potential response or not in some of the patients that we see. So we feel that by building a pipeline, we're really able to make a difference and be able to help these pets, because right now there just aren't enough options. Personally, monoclonal antibodies and immune checkpoint blockade is a fabulous avenue that I would love to see commercialized in veterinary medicine. But until we have speciation of that antibody and we know diagnostically what is being expressed on that tumor in order to target that tumor, it's going to be really tricky in order to have a strong commercially viable product to move forward with. And then, of course, when it comes to veterinary medicine, cost is one of the biggest concerns. A product that's priced more than $5,000 US is going to have a very limited market share and a very hard barrier to overcome in order to effectively be commercialized. So at every step of the way, we are constantly looking at how do we continually make this affordable? How do we know that the pet owner is going to really want to have this therapy? And what are we doing in order to advance innovation in companion animal medicine? So by being able to focus on our pipeline of oncology offerings, so the autologous cancer vaccine, a second version of that cancer vaccine, a product for lymphoma, and then we're looking at mRNA-based technologies for inoperable tumors and different immunomodulatory adjuvants that we can have intratumorally, really activate that tumor and turn it from cold to hot. We're really being able to expand what's available for pets globally in the market. So the next slides are really talking about our current product. So our first autologous cancer vaccine is made from the patient's own tumor cells. The tumor gets surgically excised and gets submitted into our laboratory. Once that tumor is in our laboratory, what we do is we take the tumor, we isolate out the cells with a mechanical dissociation. We then deactivate the tumor in order to preserve the outside architecture of the tumor cells, because what we're really focused on is being able to present back the surface tumor-associated antigens back to the immune system. We combine those deactivated tumor cells with a novel adjuvant that helps stimulate the immune system and specifically activate cytotoxic T cells. And by doing that, we're really able to provide a simple yet affordable cancer treatment option into veterinary medicine. In theory, this is a tumor agnostic approach where we're able to treat any tumor that can be surgically excised. However, what we really focus on is being able to understand what is that best avenue for treatment for that pet. One thing that we do know for a vaccine like this is that we need about 6 weeks in order to really potentiate an immune response after the series of vaccines are given. And if we believe that that patient does not have 6 weeks of overall survival, we know that may not be the best option for that pet. So to date, we've treated over 2,000 veterinary patients with this autologous cancer vaccine: dogs, cats, horses, 2 tigers actually, and a zebra as well. And this product really allows for straightforward administration in any clinical setting. This is something that I'm really passionate about, because since there are so few veterinary oncologists located, globally, it's really about being able to provide additional access to oncology therapies within any clinical practice. So after that tumor is surgically removed, it gets sent into us, where we're then able to look at performing histopath to get an accurate cancer diagnosis. And once we have that diagnosis, we know it's a malignancy, and we know we would potentially have an effect, meaning it's not too far gone. This patient has a potential to have an active immune system. Then we can move forward with the creation of the vaccine. The vaccines are administered once per week for 3 weeks. So why autologous cancer vaccines? I think there's so much beauty in being able to take what went wrong in the tumor at the time it went wrong. So being able to really capture those relevant tumor antigens, the tumor-associated antigens or the tumor-specific antigens, you're really able to take that fingerprint of that tumor. And by taking those surface proteins and preserving them in the way that takes their conformational epitopes and still maintains them, you're able to produce the vaccine without actually knowing what exactly those antigens are, because you're taking what went wrong in that patient and now presenting it back. These are therapies that are well tolerated in the thousands of patients that we've treated. We haven't seen a very increase or flux of adverse events. These are also less expensive traditionally than adjuvant chemotherapy and radiation therapy, and no special PPE is required for handling or administration. We have been able to publish our safety for equine, canine, and feline, really showcasing the safety of this approach, where adverse events could be injection site redness, irritation, or mild lethargy. We've also published data for dogs with metastatic hemangiosarcoma and showed that our vaccine had similar results or equivalent results to the maximum tolerated dose chemotherapy, which was about 3x increase in overall survival than just surgery alone. So with that, having metastatic hemangiosarcoma, which is truly one of the most aggressive canine tumors that we see to date, being able to push that needle and be able to have an option for these pets really allows for veterinarians to consider adopting this. And honestly, it really comes down to safety when the pet owner is considering what treatment type do they want to move forward with. So when we look at developing new immuno-oncology therapies in veterinary medicine, safety has to be one of the #1 concerns, along with cost and, of course, overall efficacy. With our vaccine, this is just a photograph of what is done. Tumor surgically excised and sent into our lab. What we do is we bring those tumor cells down to a single cell suspension and we deactivate the tumor. We then add a novel adjuvant that I'll talk about in the next slide. It's a series of glycoproteins and glycosaminoglycans that really allows for not only the tumor cells to attach to that adjuvant, it allows, when it's presented back, to help stimulate cytotoxic T cells. So you're able to get a systemic and abundant activation by utilizing the vaccine throughout the body. The adjuvant that we use is really a novel biomaterial that was created at Purdue University. And what our lab found at the University of Notre Dame was that by taking this biomaterial and bringing it down to a microparticulate just above nano, since it contains collagen and elastin and glycosaminoglycans, it really allows for not only a sticky particle, but it does stimulate a pro-inflammatory response and specifically activates killer T cells. So we had examined this adjuvanting property for intracellular pathogens, but then also for cancer vaccines in order to truly stimulate a cytotoxic T cell response. We've been able to showcase the uptake of this adjuvant within macrophages and really showcase that the size of the particulate really does, of course, have an influence on how much is taken up by macrophages. And we also know that the tumor cells bind to these glycosaminoglycan particulates in order to effectively be uptaken by these APCs. And the coolest thing that happens is really the T cell priming. So we've been able to showcase that the upregulation of CD80 and MHC class II in canine macrophages really allows for that upregulation of the cytotoxic T cells and effective priming of them. So when we specifically looked at hemangiosarcoma, that's canine HSA, we found that our autologous cancer vaccine was able to regulate and upregulate both CD80 and MHC class II in vitro. Since CD80 is a co-stimulatory molecule to activate T cells, and MHC class II really focuses on being able to really kind of drive them towards activation, both factors are only upregulated when we have both the tumor cells as well as the adjuvant is components within the vaccine. And this again really touches upon the published data that we have for metastatic hemangiosarcoma, where, when it comes to being able to push that needle out for survival, having equivalency to the maximum tolerated dose chemotherapy really for us showcases the ability to say, okay, we know that we're moving the needle in the right direction. What else can we do? We also have additional data for patients with high-risk mast cell tumor. We have a much larger population that we're looking to publish, but we've presented this at the Veterinary Cancer Society publicly, where we had dogs, 14 dogs with dermal mast cell tumors that were evaluated to be high risk. And one of the really interesting things is that, not only was our survival pretty strong, about 2x increase over surgery alone, the really amazing part were that nearly over 35% of those dogs were alive at the 1-year mark. And when it comes to dogs with cancer, and especially high risk metastatic disease, being able to really showcase a strong 1-year and then also a 2-year survival rate, we were able to really say that we're pushing that needle in the right direction. And that's something when it comes to the immuno-oncology space in veterinary medicine, we have to be cognizant of. It's safety, it's cost, it's efficacy, and then it's also commercial availability. If we're commercializing products that can only be used by veterinary oncologists, you've automatically limited your market to the less than 10% of owners that can actually get through their door. So when it comes to immunotherapy development, there truly is a limitation of not only animal models, but of course, reagents. There are so many times inside of our lab where we're looking at different CD18 markers or CD11A, and we're having to do a lot of validation in order to ensure that we have strong binding. So being able to pick a commercial reagent up can sometimes be a 50-50 chance if you're going to be able to get strong binding. In addition, regulatory approvals, we have a product for oral melanoma that's commercially available called Oncept. That is one product that has approval for immuno-oncology in the animal health space. But since then, there have just been not enough innovation moving fast enough through the regulatory approval process that we're looking to change. There's also a complexity of cancer that, of course, has to be appreciated. Not only the heterogeneity of the tumors, but we do not understand enough about immune escape or the representation of different immune checkpoint blockade on these tumors to really have a good appreciation for what tumors we think could have a best response for different immuno-oncology products. So lack of definitive biomarkers, just spoke to that. And then also, looking at being able to find what is an effective response can truly be different depending on the tumor type. There are tumor types that we treat pretty frequently that maybe will not affect the overall survival of that patient, but those become challenging. Now you're having a long time frame in order to understand the overall survival of that pet. And then also there's just been limited funding in this space. And that's something that we're actively looking in order to change, because we do feel that there needs to be more, because these pets deserve it. So in regards to products on the market, we have the USDA licensed melanoma vaccine. There's also a bacterial cell wall for tuberculosis immunocytin. That's a non-specific therapy that's provided intratumorally, primarily for mammary carcinoma. We are currently an unlicensed biologic being personalized, and there's another therapy by Elias Animal Health, a T-cell therapy that's currently with us on this boat. And there's also extra label use of FDA-approved drugs like HOX2 inhibitors, metronomic chemo, TKIs, or different BCG proteins that could be administered intratumorally. And then in gray at the bottom, there's a few almosts where there have almost been some B and T-cell monoclonal antibodies that were approved, almost an osteosarcoma vaccine. It just didn't get through safety. And we believe that there can be so much more done here in order to really advance the space. So future directions, we're looking at combining our therapy with radiation, different chemo. And of course, if there was a fabulous PD-L1 checkpoint inhibitor, we have some ideas as to some tumor types that we would love to be able to combine our cancer vaccine with. So with that, immunotherapy is here. Cancer vaccines are going to take a great front seat in order to really drive moving forward. And there's going to be some quick advancements. And most importantly, what we like to tell veterinarians is that not only are there tools that are available, there are going to be advancements that are coming fast. So watch out, because we're coming and the industry is about to change. So with that, I'm happy to hand it over for any questions.